commonest problems that we're faced with is dealing with people who have had ankle sprains. Now, it seems a really insignificant problem, but it remains that about 20% of people that have a significant ankle sprain will have ongoing problems. When you think about the fact that ankle sprains are the most common sporting injury, it adds up to a lot of people. Now, how do you manage ankle sprains? Generally speaking, if you sprain your ankle, and if you don't have deformity, you're not likely to have a fracture. Do I need to go to casualty, people say? That's the emergency room of a public hospital. Well, it takes a long time to work your way through a casualty department. And generally speaking, unless there's deformity, you're not likely to have a fracture. So if you have a lot of pain and a lot of swelling, as you'd expect, the best way to manage it is to use lots of ice, elevate the foot, and if possible, get hold of a boot. These boots are commonly found with physiotherapists and, ironically, in emergency departments. If this is the first time you've had an ankle sprain, the really important thing is to concentrate on the ice and the compression and the elevation. I tell people to go to the service station and get themselves a bag of ice, 5 kilo bag of ice, put half of the bag in a bucket, fill it up with water to about 2/3 of its height, and put your foot in. It's not particularly comfortable, but that will really make it cold. And once you get used to it, you can keep your foot in for 30 or 40 seconds at a time. Now, just say then you find on the following day that you still can't put your foot to the ground. Well, I would probably go and see your general practitioner at that stage. Good general practitioners know how to assess these things, and they may or may not do an X-ray. X-rays are not necessarily required, and once again, if you don't have any deformity, you don't necessarily have an X-ray. What about an MRI scan? They're not necessarily required either, although increasingly people seem to have MRI scans done as their very first investigation. I always think about these things in relation to a golden time of about 3 weeks. And if you're doing well over the first 3 weeks, and by that I mean if you're getting your movement back and you're getting foot comfortably to the ground, often say to people it's good to go to a pool and walk in deep water during that time, then you're probably on the right track and you probably don't need any investigations. But in my experience, the group of people who have trouble and who perhaps have something else wrong that needs my attention often find by about the 3-week mark that they're just not getting better. Now, in that situation, you should have an X-ray and you should probably see either an orthopaedic surgeon who has a subspecialty interest in this sort of thing, like myself, or see a physiotherapist who has good knowledge of sports. Now, there's, in my experience, a significant group of patients who need surgical treatment. And as I mentioned before, 20% of people with ankle sprains tend to have persistent issues, and those people tend to have a specific subset of injuries. So what can go wrong? What leads you to have troubles with your ankles such that you might need to see me? Once again, fail to improve by that 3 or 4 week mark. Well, look, I brought in a model of a foot, which I often use to describe things for people so that they can have an understanding of the anatomy. This is the ankle joint, and it's formed of the tibia, which is the large shin bone, the bone on the outside, which is called the fibula, and in the middle there's another bone, which is called the talus. And you can see that the 3 things together basically form the ankle joint. Now, if you fracture your ankle, you usually fracture this one here, which is called the fibula, or this one here, which is called the medial malleolus, and sometimes the back of the ankle as well, which is called the posterior malleolus. Posterior just means back, anterior means front. Now, you can see how I've drawn a couple of little lines on the top of the talus here. That's to indicate that in some people, they can knock off pieces of cartilage in this area, and that's called a talar dome lesion. Talus, the bone, dome, the top, lesion is just our description of what it is. And people who have a big ankle sprain and who tear the ligament, and the main ligament goes from here, which is the fibula, down to here, which is the talus. It's called the talofibular ligament. If you tear that, and if you virtually dislocate your ankle at the same time, you can find yourself damaging the inside of the ankle. So what does all this mean? Well, it means that if you came to see me and the MRI scan showed that you'd torn this ligament and you felt unstable, and on top of that you had some pain and or stiffness, then what we would do is we'd say, well, if you're not getting better, we'll need to have a look inside your ankle. We do this by making 2 little tiny nicks and looking inside, and you can see we can see everything inside the joint. Sometimes we also need to look in the back of the joint, because there's this little piece of bone here called the os trigonum, which can sometimes be detached. So we do that, and then the next part of this is to stabilize your ankle. And to do that, we make a little incision here. We identify this ligament, which usually just gets ripped off here, and we put a little drill hole here and bring the ligament back into place and tie it up. And what that does is it makes your ankle stable again, enables us to deal with the problems inside your ankle, and normally that's sufficient to deal with the problem. So what happens afterwards? Afterwards, you'll be immobilized for a period of time. Fairly short these days. Usually somewhere between 1 and 2 weeks we would put you in plaster. Now during that time we'd encourage you not to go to work. It's really important that you stay home, that you put your foot up, and really that you don't go out and about. Sometimes we'd let you weight bear, but because you're in a plaster, you normally would need crutches, and you'd need to stay home, elevate your foot. We'll take half an aspirin per day or something like that just to thin your blood and diminish the number of clots that you may get. Now clots are uncommon after foot and ankle surgery, but they do happen. And sometimes you would need to give us a call if you felt there was pain in your calf or that your foot was becoming unreasonably swollen.